I'm glad you were able to make it. And, it's really important that you're on because I know a lot of people in my personal life who are struggling right now to have babies. They're having a lot of more miscarriages. And so it's probably best if we start by you introducing yourself and explaining what you do in terms of helping people and couples actually achieve their family planning goals.
Okay, cool. Okay, well, thanks for having me. My name is Dr. Nidhee Sachdev. So I am a reproductive endocrinology and infertility doctor, which is a long way of saying I'm a fertility specialist. And what I do is just that. I help people who either are having a hard time getting pregnant or having miscarriages, or maybe are in a position where they're not ready to build their family and thinking about preserving their fertility. So I help patients and treat all aspects of fertility and infertility and fertility preservation. I have so I currently I practice in Newport Beach at an office called OC Fertility, and I've been there for the last 6 years. And I feel very lucky to be here to talk to you about what I do, because genuinely I have a lot of pride in what I do. Not just that, yes, I'm a doctor, but also the fact that I am able to help patients in this specific arena. Because for me, this is an aspect of life that's really important.
Nice. Yeah. So it sounds like what you're doing on a day-to-day basis is fulfilling, and that's probably inspiring you to go into the office every day because you're knowing that you're helping people, and then people are, like leaning on you for that help. But before you actually felt this kind of impact or knew you were making this impact, how did you decide that this is what you're going to specialize in? How did you feel inspired to start pursuing this specifically?
And that's a good question. So a lot of it has to do with that feeling. So when I was in med school, I realized that I was interested in women's health, and it was particularly I was just really kind of enamored by the idea that we could grow another human inside of our bodies, and I just thought it was so wild, like the physiology, and so I loved that aspect. And so I went into women's health, and when you're in residency, you learn all aspects of women's health. And a big part of it is learning how to deliver babies and caring for pregnant women. And although I really found a lot of joy in that, I kind of felt like the impact I had on people's life wasn't, as much as it was when I would talk to patients who, yes, were there to deliver a baby, but when I would learn about how they got there, whether if they were having a hard time getting pregnant, and really seeing just the impact that that process had on where they are now, I kind of felt like, for me personally, I was going to have a greater fulfillment from helping them get to that part versus helping them in that final part of having the baby.
Yeah.
Um, and that's what sparked my interest. And then, truthfully, then I learned about the field. And I just, again, was like, wow, this is really amazing. The technology is just so interesting. And truthfully, so, I graduated medical school, 13 years ago. And when I first started training, what we do, the majority of what we do now didn't exist, or we weren't doing it. Like egg freezing, when I graduated medical school, was considered experimental. Right
Really?
now, yeah, it was considered experimental. It wasn't until I want to say like 2012 that it was no longer considered experimental, and that's a huge part of how I counsel patients and what I do. And really, the field of reproductive endocrinology, or REI is what we call it for short, is vastly different. And I think that's kind of what's exciting, is that I've been doing this for a decade, and in the next decade, it might be completely different.
Yeah, that's interesting because I feel like it's been a while. At least, with IVF, I feel like that's been around for decades now. So that might be one of the older kind of technologies. But you just mentioned that in your career up till now, like you've seen the arc of the advancements, kind of accelerate. But like, what other advancements are you seeing in this field? Like, what is some of the latest technology out there?
So, okay, so you actually bring up a really interesting point, right? So IVF is what we're talking about, but it's the processes and the science behind what we're doing in IVF that has changed
Mm,
significantly. So now a huge part of treating patients is freezing eggs, embryos, and sperm. Whereas when IVF was first started, that wasn't something that was done. And the majority of our patients freeze embryos, even if their goal is to say, hey, I want to get pregnant ASAP. In the process of treating them, we're freezing embryos. And that is significantly different than it was 20, 30 years ago. And so when we're talking about technology, it's not that there's something different than IVF, it's what we're doing in the realm of IVF that's so vastly different than it was previously.
Interesting. So then with egg freezing specifically, and look, I'm learning like right now,
Yeah,
I clearly am new to this stuff, but I did some
yeah.
research. But with egg freezing, then what are the factors that people should be considering as it relates to maybe the optimal age for fertility preservation, and what is the success rate for when you are using frozen eggs for pregnancy?
So that is a really great question. It's actually a question that I think everybody should think about. But in order to answer that, I do have to go back a little bit and kind of talk about the underlying biology and physiology. Okay.
Yeah, yeah.
So
Let's do that.
so the basics of fertility, right? Are obviously men and women are different. But men and women are different in that as a male, men have the ability to reproduce sperm throughout their reproductive life. So when a male is trying to conceive, whether they're 30, 40, or 50, the sperm that they're producing is not 30, 40, or 50 years old. It's roughly around 90 days because that's the life cycle of sperm. So yeah, a male's fertility is going to decline a little bit as they get older, but not qualitatively as significant as it is for women. But for females, on the other hand, is that as women, we're born with all the eggs that we're ever going to have. And regardless of what you're doing, whether you're on birth control, trying to get pregnant, not getting pregnant, or being pregnant, every month we're losing eggs. Even for people who are like, oh, I don't get a period, they're still losing eggs every month. So,
Hmm.
from a quantitative standpoint, we have less eggs as we get older. But for most things in life, quality trumps quantity. And quality is also affected as we get older. Why? Because the eggs that we have left have now aged with us. And so for someone trying to conceive at home, really it's the eggs. So as I mentioned for men, if a male is 50 years old, his sperm isn't 50 years old, it's 90 days old. But if
Right.
somebody is 30 versus 40 and they're trying to conceive, their eggs are 30 and 40 years old. And so quantity, we could kind of assess with blood work and ultrasound. And yeah, and if you took every woman in the world and you graphed their age with their ovarian reserve, that's what we call like the number of eggs we have left. Yes, there's going to be a trend, and the line, is going to go down, and the slope of that line is going to get steeper as we hit our, mid to late 30s. But if you zoom in on that line, there could be quite a varying, you know, variations between person to person, whether they're 30 or 40. And so I could have a 30-year-old that has less eggs than a 40-year-old, but that 30-year-old's quality of her eggs is going to be greater than the 40-year-old's because they're 10 years younger.
Right.
And when we're talking about quality, really we're talking about something that's fairly tangible. It's chromosomes. So going back a step, right? Everybody came from someplace, right? If you boil it down, it's really an egg and a sperm. You can call them mom and dad, but really it's an egg and a sperm. And we all got exactly half our DNA from the egg and the sperm to equal 46 chromosomes. Now, you as a male are 46XY, and I as a female am 46XX. And so we should have gotten exactly 23 chromosomes from each. However, what people don't realize is that the egg and the sperm don't just show up with the right number of chromosomes. It's not a passive process, it's an active process. There's an actual division. So if anybody kind of like thinks back to like high school biology, we may have learned something called like meiosis. That's what's occurring. And because men are producing sperm throughout their reproductive life, that is occurring every 90 days. So that mechanism, although nothing is 100%, it's fairly well maintained. I would say in the high 80s to 90% of the sperm are going to have the appropriate chromosomes. But for women, if you're conceiving on your own, it's when you ovulate. That's when the egg says, I'm going to divide. And as we get older, there's a marked, increased error rate in when the eggs are trying to divide, that there's a greater risk of those eggs having too many or too little chromosomes. So if numerically it's not exactly what we need, it either won't fertilize, or if it does fertilize, when it's time to grow and divide to become an embryo, it either won't do that, or when it implants, you have a higher miscarriage rate. So that's a
Interesting.
very long answer to your question, in that why are women having more miscarriages when they get older, which wasn't exactly your question, but it was part of the conversation. That's the crux of it, is that statistically, the embryo that's created when we're older came from an egg that is less likely to have the appropriate chromosomes. And although not every miscarriage is due to an abnormal chromosomes, the majority of them are. And that percentage gets higher as we get older. Okay.
Interesting. And yeah, that's deep and
Yeah.
very interesting. And I mean, uh, let's take it even just a step back. Just having this conversation right now, I feel fortunate because we're all like we're here and we're having this
Yeah.
conversation, and um it's just such a miracle that this stuff is happening, and I feel like it just gets kind of taken for granted. So I feel like I just need to say that. But you were kind of touching on some of the health issues and like the aging process, and that's obviously a challenge for folks. But what are some of the other like common health issues or challenges that you're encountering in your practice? And maybe you can just talk about like what is the typical process of evaluation and treatment that you're taking people through, like from A to Z.
Totally. Before I do that, though, I do want to answer your question about the eggs because what I just said was the build up to the answer to that question. So,
Okay,
sorry,
I
sorry.
stepped on the punchline.
No, no, no. But so you have to understand that to understand what does it mean to freeze eggs and how many should you have and success rates. But really, that's the whole
Right.
goal of freezing eggs. Is because we're the youngest we're ever going to be today, right? Like
Hmm.
we're not going to get any younger as we get older. Today is the youngest we're going to be, and so the point of freezing eggs is that if you're not ready to conceive or to build your family, the point is that if we take your eggs out today, they're more likely to lead to a chromosomal normal embryo today than they are when you're older. And that's where the statistics come from. That's why the younger you are, the more likely those eggs are to lead to a live birth. And then it's also, again, just a numbers game. So in reality, the more eggs you have, the more likely you are to have one of those eggs lead to an embryo that's going to lead to a baby. And
So
so
it
that's
sounds
just pure
like you
statistics.
would actually give advice. I mean, not advice, that's a strong word, but it sounds like if someone was talking to you about this and let's say that they didn't have like a medical issue. It was like a non-medical decision. You might actually nudge them in that direction and be like, "Hey, if you want to, pursue your career, then do that. But if you're going to do that, think about freezing your eggs now because you're younger. And so when the time is right for you to actually build a family, you're going to have an egg that has a better chance of having the appropriate number of chromosomes for this to actually be successful."
Oh, 100%. I mean, I don't say nudge, like I counsel patients, right? Like as a doctor, my job is to educate people, offer them the information, and they make a decision that's best for them. But yeah, 100%. Like for instance, as a physician, as a female physician, what are the steps I had to take? I had to go to, yes, college and medical school, but then residency fellowship. And as a physician, I had to make decisions about when was the appropriate time, if and when I wanted to start a family. And so conversations I have with other young, professionals or for anybody, whether you're a professional or maybe you're just not ready to start a family, is that understanding that your fertility may or may not be a challenge for you in the future. In an ideal situation, somebody comes in when they're younger and they're, let's say, their early 30s and says, "Hey, I'm not ready to build a family yet. I'm waiting for somebody or my career, etc." They freeze their eggs. And I tell them, in the best situation possible, you freeze your eggs, you have that, you live your life, focus on your career, you find somebody you want to have a family with, however you want to do it. But when you're ready to start a family, you try and you conceive on your own and you never have to use those eggs. That's the ultimate. But if you do have to come back to use those eggs, they're there. And so when I counsel patients on freezing their eggs and numbers and statistics, I refer to, so people used to think about it as an insurance policy, which is a misnomer. Because, if let's say somebody hypothetically has fire insurance for their home and their home unfortunately catches on fire. Now that insurance is going to give you some money. It may not give you enough to build your whole home, but it's going to be something. Well, I can't give somebody part of a baby, right? It's and so it's not an insurance because we don't know what's going to happen until we come back to use them. So I think of it as an investment, right? When are you likely to get, like, it's about an ROI, your return on your investment. When are you more likely to get back on your investment? The younger you are and the more eggs that you have.
Mm.
And that's the key.
Yeah, so then in terms of somebody walking in, like what is the process of evaluation and treatment? I mean, it might be hard to answer that because everyone has such a unique and specific situation, but
Yeah.
um, like what's the maybe we start with like how many births in the US are actually done through IVF and then
Oh,
like how do you
so,
go
so
through
many,
this? Yeah.
so many, like tens of thousands, hundreds of thousands. So there's a lot with the assistance of fertility. But okay, so let's say hypothetically a person, whether they're trying to freeze eggs or having issues conceiving or whatever the issues, comes to my office. What does that look like, right? So we talk about things, I educate them, but the diagnostic workup, if somebody is considering preserving their fertility, really is just basic blood work, right? Making sure your blood count's okay. We screen for infectious disease, HIV, hepatitis, that kind of thing, and then we assess for your ovarian reserve. Now, a really important thing is that patients will say, "Can you just check to see how many eggs I have to make sure I can conceive in the future?" And
Yeah.
although I totally understand the thought process behind that, it doesn't give us that information. Because when I do blood work and say, "Hey, your ovarian reserve, the pool of eggs that you have left is, robust or lower than average," the studies show that that is not indicative of your actual fertility right now. What that is indicative of, if you tried to freeze your eggs, how would you respond? Because as I mentioned, statistically, it's a numbers game to some degree. Um, and if you have a higher ovarian reserve, you're likely to respond more robustly and get more eggs versus lower. But it doesn't say anything about your actual fertility. So there are people out there trying to conceive, and we don't know anything about their ovarian reserve. And it's possible it's quite low, but they're able to conceive on their own. And then there's people who have a high ovarian reserve, but they're still having issues conceiving. So yes, we can do that, and it gives you some information that maybe will help you determine if you do feel comfortable preserving your fertility by freezing your eggs versus not. But yes, so we do that. Um, and then we do an ultrasound. We look at the uterus and the ovaries. And looking at the ovaries, I can also get a sense of someone's ovarian reserve. Okay. And so let's say someone says, "Okay, I want to move forward and freeze their eggs. What is the process?" So I tell every patient that whether you're doing the process to freeze eggs or you're going through the process to make an embryo, as if you either want to preserve it or you want to get pregnant immediately, it's the same process for both patients. The only difference is that for somebody making an embryo is that there's sperm from someplace, whether it's a donor sperm or it's a partner. Okay, but otherwise on the patient end, if in my waiting room there are patients there and some are freezing eggs and some are, doing IVF, if they were to compare what they're doing on that day, they're doing the same thing. Okay,
Hmm.
so what's entailed, and so a background to the process is that every month, regardless of what you're doing, our body is recruiting hundreds of eggs, and dominant selection typically takes over, and we ovulate one. Okay, even if you're somebody who doesn't get periods or doesn't menstruate regularly, our body is still recruiting those follicles. So when we're going to grow those eggs and remove them for either freezing eggs or IVF, I'm not actually doing anything that's going to take away from their future. So freezing eggs in November 2023 or doing IVF in November 2023 doesn't affect their fertility in November 2025. I'm basically taking advantage of what our body was not going to use anyways. Okay. So you have to think about it as a 2 weeks of active effort on the patient's part. And they'll come in, we'll do ultrasounds, and then they'll start taking injections. And everything is typically based on the beginning of their menstrual cycle. And the injections are synthetic forms of what our brain produces. So in a spontaneous menstrual cycle, our brain produces hormones, it talks to our ovaries and gets us to grow one egg, and we typically ovulate. But now I'm giving them synthetic forms of what the brain produces, which unfortunately do come in the form of injections. The injections are intimidating for a lot of people. If anybody's ever seen anybody give themselves insulin, it's subcutaneous, which means it doesn't go into the muscle, it goes into the fat, and they're short and really thin. And once patients typically start them, they realize it's, for most, it's not as bad as I think.
Hmm.
But anyways, they're giving themselves injections for an average of about 2 weeks. And in that process, I'm seeing them a lot. I'm doing ultrasound and blood work, watching to see within their ovaries, are they growing eggs? How many are they growing? Are they growing 5, 10, 12? And we're watching to see, okay, when are those eggs going to be ready for us to take out and to retrieve? And it's about a 2 week process. And I say about because it's not like a cookie cutter that, someone starts on this day, they have the procedure on this day, which is actually really hard if you think about it from a patient standpoint. They're they're still functioning, they're living their life. Some of them may have kids, then they're also trying to get pregnant for a second, or they're freezing their eggs and they have a demanding job, and then they have to come into my office and see me for blood work and ultrasound, typically about like 6 times in 2 weeks. And then on top of that, I'm saying, hey, you're going to have a procedure, which you're going to get anesthesia, and you have to take the day off and have someone either take care of you or take care of your child so that you can do that. And I'm not going to tell you for sure when it is or what time it is until 2 days beforehand, because I won't know when you're ready. So
Wow.
that in itself is overwhelming. Like I have patients who are lawyers and they're like, "Well, I have a trial. What do I do?" I mean,
Right. Right.
so there's a lot that goes into it. But for the most part, for better for worse, we do what's in the best interest of the patient. And each person's body is going to respond a little bit differently to the medication. And so we're seeing them frequently. And sometimes it's, every 3 days or every 4 days, but sometimes I put patients on what I call the everyday plan because I just see them every day until they're ready. So that's the process of growing the eggs in their body.
So in this period, are you also doing other types of tests when it comes to like genetic tests and trying to see if there's a way to predict or maybe diagnose if they're going to have some fertility issues just based on genetics? Is there like genetic screening taking place in this time period as well, or is that later or before?
Kind of all of the above. So genetic screening is a kind of a general term, but part of the workup, if you are, you could do if you're freezing eggs, but if you're making embryos, is genetic carrier screening, trying to say, hey, are you a carrier for a disease you can pass on to your kids? And now genetics can be multiple different ways, but the most common one is what we call recessively inherited. So let's say you have a person, Tom and Sally trying to conceive together. And if Tom is a carrier for disease A and B, and Sally is not a carrier for A and B, but she is for C and D, then as long as they stick together, they're fine. But if they happen to be a carrier for the same disease, call it A, then statistically they have a 25% chance of having a baby affected with that.
Hmm,
That's not, those tests aren't saying that, oh, you have infertility or this is why, but that's genetic screening to say, are you at increased risk of having a developmental disease, um, a child with a developmental disease?
are there
Then,
specific genetic oh, sorry, go ahead.
yeah, yeah, no, there are. I mean, genetics is such a vast thing, and that's like a whole other conversation we could have.
Yeah,
But specifically, what we're looking for is I'm not looking to see are you a carrier for a disease that's going to affect you as an adult, right? I'm not trying to screen for multiple sclerosis or Alzheimer's. What I'm screening for is, are you at risk of having a baby that's going to have significant health issues?
got it.
And that's what we're looking for. But yes, and then there is additional genetic screening that we can talk about. But and forgive me for not answering your question directly, but only because to continue on the train of thought to help make this clear.
Yeah.
Um, okay, so we talked about what's entailed for somebody who is growing eggs to either freeze them or make embryos, right? So injections, blood work, and ultrasounds until they're ready. And then yes, the procedure can be kind of stressful because you don't know when it is. But what is the procedure? So the procedure is called an egg retrieval. And in our office, we actually have our IVF lab and surgery center on site. So you don't have to go anywhere else. And actually, most of our patients have no idea because it's a separate door and it's not really visible until you're there. But what happens is that you get anesthesia, and in our practice, we have a separate doctor that gives anesthesia to the patients. And so they get it through the IV, they're asleep, they're comfortable, they're not in pain, and I can focus on the patient doing the procedure. To do the procedure, there's no large incisions, but when you're being evaluated and we're undergoing the process, like I said, you're getting ultrasound, they're vaginal ultrasounds. So I'm basically taking a needle and I'm using ultrasound guidance to go through the vagina into the ovary to take the eggs out. Now that's where the anesthesia comes in because you're not in pain during the procedure. And it takes about 15 to 20 minutes. Patients wake up within a minute or two after. They hang out in the recovery room for about 30 minutes and then they're good to go home. So
Hmm.
it's a outpatient procedure. So then that day, the patients will find out how many eggs they got. Again, whether they're freezing eggs or making embryos, they will leave the office saying, "Hey, I got 8 eggs or 12 eggs, etc." If someone is freezing their eggs, then they get frozen that day. If somebody is making an embryo, then sperm, whether it be from a significant other, partner, donor sperm, then they're attempted to fertilize. And if they do fertilize and they make it to become an embryo, that's when you can do more genetic screening. You unfortunately can't genetically screen just the egg individually, which would which is why freezing eggs is a wonderful option, but that's where the unknown comes in. If somebody freezes 10 eggs, we don't know how many of those eggs, one, are chromosomally normal, and two, we don't know how many of those will fertilize and lead to an embryo. But when somebody is doing IVF to make an embryo to conceive or to bank embryos for the future, then we get more information. We'll say, okay, hey, out of 10 eggs, 8 fertilized. And when they fertilize at the very beginning of an embryo, they're 2 cells. But that 2 cells embryo needs to grow and divide to 4, 8, etc. And we let that happen in the lab over the course of about 7 days. And so we call it the fertility funnel because we start off with a certain number, and with every step, it goes down. So somebody could have 10 eggs and 8 could fertilize. And let's say out of 8, only 4 continue to grow to become these more developed embryos, which statistically is actually pretty good. But now we have 4 embryos, which is wonderful. But going back a step, We know that not all of those embryos came from an egg or even a sperm that had the appropriate chromosomes. And this is where age makes a big difference because the percentage of those embryos that are going to be chromosomally normal is dependent upon your age. And so if somebody is 30, let's say out of 4 embryos, I'd expect 3 to be chromosomally normal. If somebody is 35 out of 4, I'd expect 2 to be chromosomally normal. If somebody is 38, I'd expect 1. And if somebody
Wow.
is 40, I'd hope for 1, but sometimes we see that none are normal.
Wow.
So that is the crux of the process. I mean, in reality, when people conceive, whether it's on their own or through the help of fertility treatment, the basic concepts are the same. Egg and sperm got to meet, fertilize, grow to become an embryo, hope that it's chromosomally normal, and then implant. But the younger you are, the easier it is, or the more likely you are, I shouldn't say easier, the more likely you are to make an embryo that's chromosomally normal. And that's the crux of female infertility.
Wow. That's amazing.
Yeah.
That's really important work that you're doing. And I mean, it just goes to show that like with every passing year, I mean, there's a percentage chance that you're going to have an abnormal embryo. And that's obviously an issue. And so I have so many questions. First of all, when the eggs are frozen, where do they go? Like
Yeah. Okay. Good
is it
question.
just
Yeah.
like a huge fridge? I know that sounds like a really elementary
No.
and kind of naive question, but like where are these eggs stored and what happens if God forbid something happens to you? Like, aren't these patients like kind of having a relationship with you? I'm just curious about
Yeah.
like
Yeah.
egg storage and
Yeah.
the risks
No.
there.
No, that's a great question. It's a very common question. It's a question that everyone should ask. So we have our own IVF lab in our office, and so they're stored on site. And so they're called tanks, cryo tanks. So they're these huge tanks stored with liquid nitrogen. They're temperature controlled, and they have alarms on them and backup battery reserves, et cetera. So they're stored on site,
Okay.
and they're there. For me, although yes, I do have relationships with the patients, their eggs are at the lab, and so let's say I have a patient who, for whatever reason, decides to come back and use these embryos after I retire, right? The embryos will still be there, or the eggs will still be there, whether I'm here or not. And so what's also interesting is that people move, right?
Yeah.
I practice in Newport Beach. Patients have moved to New York or to Chicago or wherever, and you can ship your eggs or embryos to where you are in the new clinic.
Oh,
So,
interesting.
so they're not stuck with whatever clinic or practice you go to.
And then what mechanisms do you have in place to prevent human error? Like uh, just making sure that the person who is freezing the eggs actually is inputted in the system as that person. I know it's like I just feel like there could be human error involved in this,
Yeah.
and that could be huge in terms of like from your perspective, from an ethical perspective, from like a law perspective, like how do you ensure that the eggs are actually that person's eggs for that entire journey?
Yeah, it's a good question. So, I mean, we have two-person identification systems. We have, like barcodes and digital things that are in there. So we have lots of different mechanisms that are in place. And also, it's kind of a volume thing, right? I mean, I can't speak for every clinic, but we're not like a factory. We don't have like thousands of people coming in. And so, we're a boutique practice. And so we control our volume to make sure from a quality standpoint, it's appropriate. Um, and so, yeah. And then when patients do go to use their embryos and they do a transfer, it's a whole thing where we have the labels from different things and we have to confirm. And I, as a physician, have to confirm and they have to confirm the name and date of birth and all those things. So it's a process. But yeah, it's a valid question and a valid concern.
Got it. But there's mechanisms in place, and okay, that's interesting to
Yeah.
know. So you were talking about earlier, like you have some patients who are, let's say, a lawyer, and then they may be on trial, and you might have patients that are coming in to see you every single day, and some people that are coming in to see you every few days. And at the very beginning of the conversation, you just talked about like how it was so fulfilling to get people to the point where they can actually get pregnant versus being the person that was helping with delivery of the baby. And so obviously, like I'm just thinking, you're dealing with so many emotions, you're dealing with so many moments where a person's life and their experience is being impacted so emotionally, psychologically, there's a lot going on, and you might have to, consider some of that or even have conversations about some of that. So I'm curious if you work closely with mental health professionals as part of this entire process. Do you sometimes have to refer a mental health professional as part of a patient's care? Like, how does all that fit in? Because I imagine just from a psychological and emotional perspective, there's just a lot going on here.
No, you're right. I mean, there's a lot that goes into it. And so the benefit of our practice is that I see my patients every time they come in. So, we don't have like, every time a patient comes in, they'll see myself. And for some reason I'm in surgery or out of town, they'll see my partner. So, but we're having conversations about things all the time. And so, I get to know the patients really well, and I can get a sense if something is off. And yes, when they need to be referred, yeah, we have therapists, we have psychiatrists, we have reproductive psychiatrists and things. But I will say though, and this is, not specific to me, I think just medicine is changing and evolving. And I think, you know, the newer generations of healthcare providers, particularly fertility providers, we're just more in tune. I think our EQs are higher
Mm.
than, people who were doing it 20, 30 years ago. I mean, and you see that for everything. I'm sure parents have more EQs than our generations of parents. But as a result, I think that I'm able to connect with my patients a little bit more deeply. And by no means am I saying that I replace a therapist, but I'm able to kind of ask questions and check in on them. And I think those little things actually help significantly.
Yeah. I mean, I imagine like there's got to be all this education and support. I mean, this is like a huge decision for people. So you have to like probably find yourself in moments where you have to do a lot of education about helping them make this like informed decision. You have to talk about all the potential risks, potential complications. Maybe you're talking about like ethical conversations and considerations.
Yeah,
I mean, I imagine
totally.
like the full
Ethics.
spectrum of
Yeah.
it exists.
Ethics is a big one. And also, honestly, like a lot of it's things that like people wouldn't have thought to talk about, like, I mean, for instance, when talking about IVF, sometimes, I mean, the statistics are unpredictable. Sometimes we're pleasantly surprised and sometimes we're disappointed. But one conversation to have is, let's say I have a patient who has a child and looking for a second. Or let's say they have two children and they're looking for a third. And when talking about IVF, that the number of embryos that they have, we could be, pleasantly surprised, and they get multiple embryos. And even after we genetically test them, they're chromosomally normal, which from an outcome standpoint is wonderful. But some patients might say, well, I only want one more child. And if I have, let's say, three normal embryos, I'm not going to feel good about having two embryos that don't get used. Because for some people, they really
Oh,
feel like that's a life, right?
wow.
And so, whereas other patients don't feel as uncomfortable about it. And truthfully, a lot of people don't even think about that until it comes up. So there's a lot of ethical things. And then another thing is that when we genetically test the embryos, we're looking to see, okay, what are the chromosomes, the 46XX or 46XY? And, one of the chromosomally abnormal um, embryos are ones with Down syndrome, an extra copy of 21. And so typically, if they're chromosomally abnormal, we don't transfer them, although there are some places doing studies to transfer abnormal embryos, but we only transfer the ones that are chromosomally normal. And so some patients might say, well, that technically that embryo that's trisomy 21 could lead to a live birth, and that's a pregnancy that I would want to have because there are patients with Down syndrome of varying degrees, and regardless, and some patients are just like, well, I would never terminate a pregnancy, and that's one that could lead to live birth. That makes me uncomfortable, and I respect that. I totally respect that. But I just say, if that makes you uncomfortable, maybe the genetic screening is not the appropriate option for you.
Hmm.
Um, and so there's just so many things you have to talk to about patients about, and honestly, and internal conversations that people need to have amongst each other to make a decision.
Yeah, that's really interesting. And at the end of the day, it comes down to, how they want to move forward. And if they can look at themselves in the mirror at night, that's really all everything comes down to. And um, yeah, you just kind of have to like maybe guide them and hold their hand. But if we're talking about ethical considerations, and earlier we were talking about some of the advancements in the technology that at least you've seen. I actually read an article this weekend in the Wall Street Journal, and it was talking about the new technologies for creating genetically related children and how it could transform family life, and it can give infertile women who are unable to have babies more options for parenthood, and even like same-sex couples more options for parenthood. And according to this article, there's a Japanese biologist who earlier this year said that it's possible to create a human egg from skin cells, because him and his team of colleagues, they actually turned skin cells from male mice into mice eggs and then use them to breed baby mice. And so you have that going on in one part of the world. And then there's another part of the world in Berkeley where there's, a team of scientists, and they're trying to make eggs outside of ovaries. And so the bottom line is, like, there's all these techniques coming out, or at least being studied and pursued, that could allow for people to have more options when it comes to parenthood. And it's the reason I'm bringing this up is, first of all, it touches on the technology aspect of it, but it also touches on, like, kind of the ethical aspect of it, because if you think about it, it's like you could have a mother that is the person that supplied the egg. You can have the mother that actually gave birth. You can have someone who calls himself a mother just because they raised a child. So typically we think about a mother as the person who had the egg, gave birth, and raised the child. But now, with all this technology and all these different options, technically a person could call themselves a mother based on three different ways of being a mother. And so the reason I'm bringing that up is because I find it so interesting. Like, we were talking about the EQ just a moment ago, and it's like, if you really want to understand what it's like to be another human, if you really want to show empathy, if you really want to put yourself in another person's shoes, you now kind of technically have to think about it from three different experiences, right? So if I'm looking at a mother, in my brain, I can't just think of them as the person who supplied the egg, gave birth, and raised the child. They could have been one of those kind of quote unquote characters. And so my point is that, like, when you're talking to someone, you just have to, like, kind of consider extra layers here as these types of technologies come out. And so I guess that's a lot of words, but my question to you is, how do you feel about that? Like, how do you feel about the thought that maybe we can have thousands of eggs from skin cells, and then ultimately a set of people can, like, just pick the one they want, and it becomes like this child is a product and you're just trying to make the best product possible, which is a very bizarre thought.
Well, so I totally respect what you're saying, but I think from my aspect of it, like this is what I do. I help people build a family. So I always say there's many beautiful ways to build a family, and a big part of what we do is reproductive medicine is helping people build their families that maybe not come in quote unquote the traditional way that you're speaking of, right? And so one thing is like same-sex female couples. They have the advantage of having two people's ovaries and two people's uteruses. So there's something called reciprocal IVF that is done very frequently, and is really a beautiful way to build a family. Where we'll take the eggs from one partner and get sperm from someplace and make an embryo, and the other partner will carry it. Um, and so then they're both able to be a part of that process. And another like
Mm.
really important way to build a family is a donor egg. And so what's a donor egg? So we talked about age and things, and also genetics. And so sometimes patients are in a position where they aren't able to conceive, or choose not to conceive with their own eggs. But instead, they can use the eggs of somebody else who's of a greater reproductive potential, likely because they're younger. And those eggs can be fertilized with sperm of whoever, and then can be transferred into them to carry, or a gestational carrier. And that is a very common way to build a family, that we see all the time. And I've had patients who are, and I always tell patients that, like, how you feel about one option today may not be how you feel about that option in a year or tomorrow, however. And I've had patients ask me that. They'll say, but that child isn't necessarily biologically related to me. And yes, however, I mean, you've ever heard of, how people say, oh, married couples start to look alike? Well, why is that? Right? That they don't share DNA, but it's their mannerisms. They're living in the same house. They'll they have the same routines. They're eating the same food, possibly same sun exposure. Children will mimic their parents' facial expressions. And so DNA in itself, I don't think is the only thing that builds a family or ties someone to one another. And I am very comfortable with that just because of what I do. And I see people build their families in so many different ways. So going back to what you're saying, and that gives me hope that we're not limited to just someone's ovaries and their eggs to build their family.
Yeah. Yeah, no, obviously more options. I mean, from one side is really good. I think just from the other side of thinking about it is like if uh, if this matters to people, but like you can separate yourself. Like the mother, like in that example, like the mother can just separate themselves and be like, well, this is not my biological kid, so I don't really have a connection to it. So if that kind of stuff matters to you, then you take it into account. But if just having
Yeah,
more options for the most ideal, most successful chance of having a baby is what is most important to you, then again, it's just going back to like all the things that
yeah,
someone needs to consider.
totally. And it's all about intention. When someone sits in my
Mm,
office and is and we're talking about donor egg, that person is intentional about building their family and growing their family in a way that they are gonna, like that's intentional. They want that. They will provide love and warmth and that sort. And if somebody doesn't feel that way, then that's not something that they're gonna do.
yeah.
So it's all about intention and things of that sort. I mean, in terms of ethical things, age, right? Like 50 years ago, the idea of a 53-year-old person having a baby may have seemed absurd, but now we're all living longer. We're living different lives. So who's to say at what age should we cut someone off as to when they can become a parent? Like, what is it? Al Pacino had a baby at 80, right? And so the key is first do no harm. So we don't necessarily want to get someone pregnant that we think is going to have a significantly complicated pregnancy or put that fetus at risk. But within reason, yes, we can. A donor egg is how we successfully help older women conceive. So yeah, there's a lot of ethical things that go into what we do, which to me I think makes it more interesting.
Yeah. We've talked about aging a lot, and obviously, like zero people in the history of life have ever been able to beat time. But,
Yeah.
but so when you're sitting and thinking about lifestyle factors, I feel like diet has to do something with this. But what are you telling people in terms of like how they can optimize their reproductive health?
Yeah. So this is a really important one. And I try to be very thoughtful about the conversation because, you know, a lot of the people sitting, across from my desk are looking for something that they can blame upon themselves. And yes, there are tangible things that we can do to improve things, but people are only human, right? And you can only do so much. So obvious ones are smoking. So cigarette smoke, tobacco smoke is why it's that's the worst thing you could do for your fertility from an ovarian
Mm.
reserve standpoint and a sperm standpoint. Patients who are smoking has been shown to have lower ovarian reserves in comparison to those who don't. Longer time to conception, increased miscarriage rates. That's a really important one. Marijuana, CBD. I'd recommend the patients if they're trying to conceive to cut that out. There are some studies that show that it can affect, sperm's ability to fertilize eggs. It can decrease fertility. It's not, as it's becoming legal in different places, I think more patients are becoming open to it. So I think we're going to need more studies. But I always tell patients, like, look, everybody knows somebody who's doing things that they're instructed not to do and is conceiving. But
Yeah.
if you aren't getting pregnant, right, there's clearly something going on. And sometimes it's that, but many times we don't have that aha moment. It's multifactorial. So if there's something we know that is not positively contributing to it, I say stop it. And there's pros and cons to everything, but yeah. So cigarette smoking, marijuana, CBD, I say that. The other things are lifestyle factors. For patients who have a high BMI or overweight, if you can, I say focus on lifestyle factors, watching what you eat, increasing your physical activity. And I don't necessarily look at the number. I'm not saying, somebody is 250, you need to be 245. What I'm saying is take the time to put your best foot forward. And if you are making better choices and you are, eating less processed foods, you're eating leaner meats, and you are taking the time to go for a walk 30 minutes a day, you overall are going to be healthier and feel healthier. So whether you lost a pound or 10 pounds or 15 pounds, it doesn't mean anything to me. To me, it's about the intentions of getting healthier.
Yeah.
Um,
Because
and
that's
it's
triggering the mindset too. Like once your mind is in a healthier place, the rest of your body is probably going to be in a healthier place. And then that's going to allow you
Yes,
to conceive,
Yes.
and
Yeah.
it's all
And it's,
mindset.
anybody who knows that, like, losing weight isn't necessarily, like you do this and this happens, right? You can lose weight and then you can plateau and you can gain weight. So focusing on the numbers, I think, is just a setback. I think it's, like you said, a mindset. Um, and then, there's other
Consistency,
things.
consistency.
Yes, exactly. And then there's other things like, there's these things called endocrine disruptors where, it's in the plastics, it's in like the thermal papers that we get for receipts. So what I advise patients is, to get rid of your plastics and get glass Tupperware, stainless steel mugs. Everyone's got a Stanley, that kind of stuff. So those things that they're not going to help you right away. If you come to me and you're 40 and you're having a hard time getting pregnant, I don't know if it's in your best interest to stop, doing treatment to do all these things and then to come back 6 months later because it's a risk benefit. But I think that whether you're trying to get pregnant or not, I think that is a helpful thing to do. So, I mean, it's all of those things. And then if somebody, let's say they do have an underlying health issue, let's say they have inflammatory bowel disease or rheumatoid arthritis or something autoimmune like that. If you're having a flare or maybe your inflammatory bowel disease is not under control, getting that under control is going to overall help your overall health, and that's going to help your fertility.
Yeah. The microplastics is huge. I mean, there's like apparently studies out there that have shown an increase in microplastics and the correlation to the decline in birth rate and how much harder it is. And so, yeah, I don't know how we're really going to figure out the microplastic situation, considering most of us have microplastics floating in our bloodstream at this point, given
Yeah,
the environmental factors and the way we've kind of all lived and grown up in the last 30 years. But yeah, there's like a bunch of toxins out there that are in our bloodstream that have a huge impact on this.
yeah. So I mean, but the hard thing is that patients will come and say, "Okay, we're having a hard time getting pregnant. Tell me why."
Yeah,
And
right.
right, and I always say, oftentimes when we find the why, that's a hurdle you have to overcome, and sometimes overcoming that hurdle is not easy. When we don't have the why, that means it's a little bit of this and a little bit of that. It's multifactorial, and with treatment, typically we can overcome it.
Nice. So in the as we wrap up here, just a couple more questions in terms of like how you think about the future of this medicine and this technology. Do you have any insight in like the coming years? What kind of exciting opportunities are out there, or maybe even challenges?
Yeah, I mean, I think what's exciting is that we're educating people more, right? And I think, you know, people are coming to us to freeze eggs earlier, which I think is going to overall increase success rates significantly. Because, I mean, look, it's 2023, right? Like the days of people saying, oh, you should just, start a family as soon as you can are not necessarily there. People want to plan, they want to take their time. And I totally respect that. But the hard thing is that, if somebody says, okay, I have met my partner, we want to have kids, but we're going to wait 5 years, and that 5 years makes you 43, that makes it harder for you to conceive at that time. So understanding what fertility preservation is, whether freezing eggs or banking embryos, I think that we're seeing patients do that earlier, which is going to change the outcomes dramatically. I think also as we're getting more insurance coverage, that has helped significantly as well. I'm seeing a lot more patients with insurance coverage to freeze their eggs, and that's actually encouraging them to freeze their eggs. And they're able to do it at a younger age. And I think just access to care, right, as more more employers are offering fertility coverage, um, more people are going to be able to do it. And I think that also makes a difference because, again, time matters and age matters. And so if somebody has the opportunity to get into treatment sooner, that's going to help their overall outcomes versus somebody having to wait a longer period of time because maybe it's out of reach financially for them. Or they just don't have that kick from having their insurance benefits say you have coverage to follow up. So I mean, I think that is promising. And I also think technology is getting better. I think, with what we're doing in the IVF lab, that's getting better. I think as we're doing genetic screening of embryos, we're going to get better at identifying which embryos are more likely to implant. So I think technology is improving. I think that is really helpful. And I think just by educating the masses more, the stigma of fertility treatment is going to be lower. And so people are more inclined to do treatment earlier, which ultimately is going to improve their outcomes.
Yeah. That answer actually just popped something in my head. I mean, if we're thinking
Yeah.
about all the layers of culture and society, I'd be curious what the field of fertility, the professionals there, how are they engaging in the conversation around the increase in transgender people, and if there's options that are unique to them, or challenges that are unique to them that they may face in terms of preserving their fertility before or during, or I guess after transitioning? Just curious about that,
Oh,
if that's coming
that
up
is a
more and more.
yeah, no, that's a great question. And that is a really important aspect of what we do. So, for transgender patients, let's say it's a transgender male. So they were born a female and they're transitioning into becoming a male. So they have the option of freezing their eggs, preserving their fertility to freeze their eggs that when they have a partner in the future, whether it's a female or a male, they can then fertilize those eggs with sperm, right? And if it's a transgender female, if you have a male who's transitioning into a female, they can freeze sperm. And things to consider for that is that for a lot of these patients, they are ready to move forward into their new life, right? And so they're transitioning and they're taking the hormones. So let's say that they aren't offered fertility preservation before they start their hormone replacement therapy. And then they need to then go back. Well, then they have to stop that. But now they are a male, right? They don't necessarily want to go back to where they were before they stop the medication and be treated as a female, which is a really important thing to think about because it's not just physiologic, it's not just hormones, it's also mental and emotional, which is part of
Yeah.
it. And in the process of preserving their fertility is an important step for them as they move forward. And
Yeah.
so, and part of the transgender population is that as we're educating people about it, I think people are making the decision to make that transition earlier, which is hard because then they're having to make these decisions about preserving their fertility when they're younger, they're 15, 16, 17. And it's a conversation that they're having with their parents. But I've had many like conversations with parents about it. But I do think it's really important that we continue to educate people because it's not necessarily just 25, 26, 27 year olds who are going through this. It's also younger people. Um,
Yeah.
and so having that, I can imagine that it's a lot to, there's so many appointments, so many things you have to think about. And this is an added layer, but just educating people about it is something else that's on the radar, much like it was for cancer patients. So for many forms of cancer, women are diagnosed with them when they haven't completed their family building journey. And so when patients get chemotherapy, it depends on the type of cancer and the type of chemotherapy. But what that does is chemotherapy acts on rapidly dividing cells. So it's the goal is to kill the cancer cells, but in the process, it kills your germ cells, which are for men sperm and for women, their eggs. So at the end of it, they're in menopause. And if they want to build their family then they can't. And
Wow.
so and so for a lot of women, it's a lot because they are diagnosed with cancer, are going to start treatment. But if they aren't educated about their options to preserve their fertility, then they will go through treatment and then at the end not have the opportunity to have frozen their eggs or make embryos prior to the chemo. So like this is, breast cancer awareness month, and breast cancer is really important because, many women are diagnosed in their 30s and early 40s. And really, what the studies have shown is that if they go through the process of preserving their fertility, either freezing eggs or making embryos before they get their chemotherapy, their outcomes aren't significantly different. But their overall, because the breast cancer survival rates are so high these days. So we're not just focused on survival, we're on, it's called thrivership, right? Like, what are their
Right.
lives going to
Right.
be afterwards?
Yeah.
And so for many women, having not only gotten cancer and have to go through the treatment, but no longer having that option to build their family is devastating. And so we've seen that educating providers and people about their options for oncofertility and fertility preservation has dramatically increased people's access to care. Sort of going back to the transgender population by again educating people. Hopefully that'll do the same in that category of patients.
Wow, that's an amazing connection. I didn't I've never obviously thought about that, so I appreciate you
Yeah.
making that connection. And yeah, this is
Yeah.
all about education and providing more options. And I think that based on this conversation, I feel like there are going to be a lot more opportunities for people moving forward. Like the advancement's going to be really interesting to watch, and we're just going to keep advancing like the human species as a result of like the work that people like you are doing. And so I just feel like this has been a really insightful conversation. I know I feel like I'm a little bit more knowledgeable, a little bit more up to date in terms of like what's going on in your world, in the world of reproductive technology. And this little software update that I just went through, I feel like is going to help me better connect to the person that I'm talking to, because it just again highlights the spectrum of people that exist and the various types of scenarios that anyone could be going through. And so for me, when I'm having this conversation and just kind of digesting it right now, it's like I feel like I'm going to be able to just better connect on a human level, just knowing that the person I'm talking to could be in one of these situations. And so it's like, how do you put yourself in that person's shoes and see the world from their perspective? And so, yeah, I mean, I think that's just great work out of you. And it probably obviously feels good to know that you go into the office every day and you're helping people. And I just feel really fortunate that we had this conversation.
Yeah, well, thanks for having me. And obviously, this has been a long time coming because many people may not know, but you are quite literally my brother from another mother. So,
Yeah.
so it's nice. So for any of my patients who are happen to be watching, this is my brother-in-law who I always talk about, who has this awesome podcast. So this has been great. I mean, I've had the opportunity to watch, to listen, and to watch many of your podcasts and watch you grow. And it's actually really, I feel honored that you invited me to talk and to share about what I do because I love you. Obviously, I love you and I love your podcast. So this is great.
Well, I love you too. And this is because, every time we met for the holidays, it's like I would learn something new about what you're
Yeah.
doing. And then it got to a point where we just needed to have you on. And so for all my
Yeah.
friends that are listening, this is the doctor that I've talked about is a fertility specialist. And so here you go, bringing it all home.
Yeah.
I'll see
Full
you at the
circle.
holidays.
All right. I'll tell mommy say hi.
All right.
Bye.